Dear students, we shall see about biotransformation in this class. Biotransformation is the chemical alteration of the drug in the body. The main purpose of biotransformation is to render the non-polar or lipid-soluble compounds into polar or lipid-insoluble substances so that they don't get reabsorbed back in the renal tubules and get excreted easily. The primary site for drug metabolism occurs in the liver. The other sites are kidney, intestine, lungs, and plasma. The implications of biotransformation. So either the drug may get inactivated, example ibuprofen, paracetamol, lidocaine, etc. So these drugs after biotransformation they get inactivated, or sometimes biotransformation may produce some active metabolite from the drug. So, for example, morphine produces an active metabolite, morphine 6-glucuronide, which also has therapeutic effect. So, similarly, we have a lot of examples: procainamide, diazepam, digitoxin, imipramine, amitriptyline, codeine, etc. So, these drugs they produce active metabolite as a result of biotransformation, so that the therapeutic effect is prolonged. There are two types of biotransformation: phase 1 or non-synthetic or functionalization reactions, phase 2 or synthetic or conjugation reactions. A drug may undergo phase 1 metabolism or biotransformation, and it might produce a metabolite which is inactive and it gets excreted directly. Or sometimes a drug may undergo phase 1 biotransformation. It produces a metabolite which again undergoes phase 2 biotransformation, and again a metabolite is produced which is then excreted. So a drug may undergo phase 1 and phase 2 or phase 1 alone. Similarly, a drug may undergo phase 2 metabolism alone, which produces a metabolite and gets excreted. So a drug can go through any of these steps. We shall see some of the phase 1 or non-synthetic reactions: oxidation, reduction, hydrolysis, cyclization, decyclization. These are some of the phase 1 reactions. In oxidation, there is addition of oxygen or negatively charged radical, or removal of hydrogen or positively charged radical. Hydroxylation, oxygenation, dealkylation, oxidative deamination, these are examples of some of oxidation reactions. And in reduction reaction, mostly alcohols, aldehydes, quinones. So these compounds are reduced. So these are some of the examples of drugs which undergo reduction reactions. In hydrolysis, there is cleavage of drug molecule by taking up a molecule of water. And these drugs undergo hydrolysis reactions. You have cholinesterase, procaine, lidocaine, procainamide, etc. Cyclization reaction involves formation of ring structure from a straight compound. Decyclization reaction means opening up of a ring structure of a cyclic drug molecule. So all these reactions are phase 1 or non-synthetic reactions. And about phase 2 reactions or synthetic reactions or conjugation reactions. So here you have glucuronide conjugation. So the compounds with hydroxyl or carboxylic acid group. So these compounds they undergo glucuronide conjugation. And the enzymes which is involved in this type of conjugation is UDP glucuronylyl transferases or UGTs. And these are the examples of drugs which undergoes this type of conjugation reaction. You have chloramphenicol, aspirin, paracetamol, diazepam, etc. And apart from drugs, some endogenous substrates like bilirubin, steroidal hormones, and thyroxine, they also undergo glucuronide conjugation. And the drugs which gets conjugated through this reaction may undergo enterohepatic cycling again and gets reabsorbed back into the systemic circulation. Okay, so these are examples of drugs which undergoes enterohepatic cycling. We have phenolphthalein, OZPs, etc. Then you have acetylation. So this is another synthetic reaction or phase 2 reaction. So here compounds with amino or hydrogen residues, they undergo acetylation reaction. The enzyme involved is acetyl-CoA. These are the drugs which undergoes this acetylation reaction. This acetylation reaction shows genetic polymorphism. So the rate of acetylation may differ depending upon the genetic makeup of the individual. So you have slow acetylators and fast acetylators depending upon their genetic makeup. The next reaction is methylation reaction. This involves compounds with amines and phenols and methyl transferases or enzymes which is involved in this methylation reaction. And adrenaline, histamine, nicotinic acid, methyl dopa, captopril. These are some of the drugs which undergoes methylation reaction. Then you have glycine conjugation. Here you have salicylates and nicotinic acid. These are drugs which undergoes glycine conjugation. Sulfate conjugation, phenolic compounds and steroids undergo sulfate conjugation. Sulfotransferases or the enzymes which is involved in the sulfate conjugation, and these are examples of drugs which undergoes. And glutathione conjugation, compounds with quinone or epoxide intermediates, they undergo glutathione conjugation. Glutathione S transferase is the enzyme which is involved in this. And paracetamol is an example of drug which undergoes glutathione conjugation. And ribonucleoside and nucleotide synthesis, this is another synthetic reaction. Mostly purine and pyrimidine antimetabolites undergo this type of synthetic reaction. So most of the drugs which is used in cancer chemotherapy or examples of drugs which undergoes this type of synthetic reaction. So the enzymes which are involved in this biotransformation reaction or drug metabolizing enzymes, they can be broadly classified into microsomal and non-microsomal enzymes. So microsomal enzymes, they are located on the smooth endoplasmic reticulum. Monooxygenases, cytochrome P450, UGTs, epoxide hydrolysases. So these are few examples of microsomal enzymes. They catalyze most of the oxidation reduction hydrolysis of phase 1 reactions and glucuronide conjugation. So these are the reactions mostly metabolized by these microsomal enzymes. The one most important point you should remember about this is these microsomal enzymes are inducible. So these enzymes are involved in many drug interactions because we have a few drugs which induce this microsomal enzymes, thereby enhancing the metabolism of other drug when they are given concurrently. And non-microsomal enzymes, these are present in the cytoplasm and mitochondria of the hepatic cells. Esterases, amidases, flavoprotein oxidases, and these are a few examples of non-microsomal enzymes. They catalyze some oxidation and reduction, hydrolytic reactions, and most of the conjugation reaction except glucuronide conjugation. So these are catalyzed by non-microsomal enzymes. So the glucuronide conjugation is catalyzed by these microsomal enzymes. And it is not inducible, and hence this is not very important. They don't play an important role in drug interactions, but they show genetic polymorphism. So these enzymes are prone to have genetic polymorphism. So example, acetyltransferases and pseudocholinesterases. Hoffman elimination is a process in which the drug gets inactivated in the body fluids by spontaneous molecular rearrangement without the agency of any enzyme. So far we saw biotransformation reaction, phase 1 and phase 2 reactions, which involve enzymes, which can be either microsomal or non-microsomal enzymes. Here in Hoffman elimination, there is no involvement of any enzyme. The elimination occurs by spontaneous molecular rearrangement. So the example of the drug which undergoes Hoffman elimination is atracurium. And we saw that the cytochrome P450 enzymes or microsomal enzymes, which is involved in many biotransformation reactions. So here you have many subfamilies of cytochrome P450 enzymes. So you have 3A4, 3A5, 2D6, 2C8, and 2C9. And these are the drugs which is metabolized by this particular family of cytochrome enzyme, and these are the drugs which inhibits this enzyme, and these are the drugs which induces this enzyme. So when an enzyme inhibitor, for example erythromycin, is a cytochrome 3A4 enzyme inhibitor, so when this erythromycin is combined with, or when it is given along with any of these drugs which is metabolized by the same enzyme, then what happens, the metabolism of that particular drug gets inhibited, and the plasma level of the drug will be raised, will be increased. So this might lead to toxicity. And similarly, these are the drugs which induces this enzyme. That means it increases the synthesis of this enzyme. So when any of these drugs or any of these enzyme inducer is given along with these drugs, then the metabolism of this drug will be fastened, or there will be increased rate of metabolism of this drug because of this enzyme induction, and there might be reduction in the therapeutic effect of the drug. So this is the concept of drug interaction when an enzyme inhibitor or when an enzyme inducer is given along with any drug which is metabolized by the same cytochrome P enzyme. And similarly, we have the drugs which gets metabolized by the specific cytochrome enzyme. These are some other cytochrome P enzymes. You have 2C9, 2C19, 1A1, 1A2, 2E1, 2B6, etc. And these are drugs metabolized by that specific cytochrome enzyme. And these are enzyme inhibitors and inducers of the specific cytochrome enzymes. So the therapeutic application of this enzyme inhibition is you have a boosted HIV protease inhibitor strategy. So HIV infection requires therapy with multiple drugs. Okay, protease inhibitor is a group of drug which is used in the management of HIV infection. So this protease inhibitor is a potent CYP3A4 enzyme inhibitor. So when ritonavir, which is a protease inhibitor, low dose of ritonavir, when it is given along with any other drug which is used in the management of HIV infection, because of the inhibitory enzyme inhibitory action, the levels of the drugs like other drugs which is used in the HIV infection is increased, thereby the therapeutic effect is enhanced. So this is called as boosted HIV inhibitor strategy, and this is a therapeutic application of enzyme inhibition. And similarly, the consequences of microsomal enzyme induction. So what happens when an enzyme inducer is given along with a drug? So failure of contraception with OCPs can occur. So when an enzyme inducer is given along with oral contraceptive pills, sometimes the contraceptive failure can occur, and when it is given along with anti-HIV drugs, loss of anti-HIV action can occur. And tolerance, so if the drug induces its own metabolism, which we call it as autoinduction, this is especially seen with carbamazepine, which is an anti-epileptic drug. So it induces its own metabolism. So in that case, tolerance to the therapeutic effect of the drug can occur. Precipitation of acute intermittent porphyria. Sometimes enzyme induction, it induces aminolevulinic acid, ALA synthetase, which is an enzyme involved in porphyrin synthesis. So when the induction of this enzyme happens, there is increased porphyrin synthesis and precipitation of acute intermittent porphyria can occur. So enzyme induction can induce synthesis of porphyrin as well. Some of the therapeutic uses of enzyme inductions are congenital non-hemolytic jaundice. So in this case, there is a deficient glucuronidation of bilirubin. So phenobarbital, which is an enzyme inducer, when it is given in this condition, it hastens the clearance of jaundice by inducing the glucuronide conjugate enzyme and thereby increasing the conjugation of bilirubin. And in chronic poisoning, faster metabolism of the accumulated poisonous substances occur when an enzyme inducer is given. So these are some therapeutic uses of enzyme induction. Okay, first pass metabolism or pre-systemic metabolism. So this is metabolism of a drug during its passage from the site of absorption into systemic circulation. So whenever a drug is given orally, it passes from the gut wall, enters into the portal circulation, goes to liver, and then again comes back to systemic circulation. So the sites of first pass metabolism are liver, intestinal wall, skin, lungs. Liver is a major site of first pass metabolism. So we can bypass this first pass metabolism by giving alternate routes of administration like sublingual route, transdermal, parenteral routes. So when drugs are given by these routes, we can bypass this first pass metabolism. So these are examples of drugs which has high first pass metabolism, intermediate first pass metabolism, and low first pass metabolism. So here, whenever there is high first pass metabolism, usually the drugs need a very higher oral dose in order to compensate for that, or sometimes oral dose or the oral route of administration is not possible with certain drugs because of its very high first pass metabolism. So these are some of the examples of drugs where you can give these drugs only through parenteral route. And low first pass metabolism means these drugs are preferred for oral route because high bioavailability can be attained because of low first pass metabolism through oral route itself. And these are the examples of drugs with intermediate first pass metabolism. What are the attributes of drugs with high first pass metabolism? Oral dose is always higher than other routes of administration, and there is marked individual variation in the oral dose due to differences in the extent of first pass metabolism between different individuals. And whenever a drug with high first pass metabolism is given orally and the patient has liver disease in which this metabolism will be compromised, the bioavailability will be increased drastically, and you should be very careful about the dose. And oral bioavailability of a drug is increased if another drug competing with it in the first pass metabolism is given concurrently. So this is what we were talking about, the drug interactions. Hepatic extraction ratio of a drug is the fraction of the absorbed drug prevented by the liver from reaching the systemic circulation. So this includes both pre-systemic metabolism or first pass metabolism and direct excretion of the drug into the bile without metabolism. So both these processes are included in the hepatic extraction ratio. So sometimes a drug might get metabolized and sometimes a drug might not get metabolized but directly excreted into the bile. So whenever a drug is presented to the liver, it actually depends on the hepatic blood flow. So hepatic blood flow determines the amount of drug which is presented into the liver for metabolism, and clearance of the drug by the liver is the actual metabolism, the intrinsic metabolism of the drug in the liver. So extraction ratio is clearance of the drug by the liver or the intrinsic metabolism of the drug by the liver divided by hepatic blood flow. So metabolism of the drugs with high hepatic extraction is dependent on the liver blood flow. So whenever a drug has high metabolism, high intrinsic metabolism in the liver, more hepatic blood flow means more metabolism in the liver. So for example, the lidocaine is one of the example of a drug with high extraction ratio, that is high intrinsic metabolism in the liver. So whenever it depends on the hepatic blood flow. So whenever the hepatic blood flow is decreased when we use drugs like propranolol or beta blocker along with lidocaine, so what happens, only some amount of drug is presented to the liver, and hence the clearance also will be very low, that is the metabolism also will be very low. So this is an example of a drug with the high intrinsic metabolism or high extraction ratio, where the metabolism is affected by hepatic blood flow. So whenever there is whenever something happens which decreases the hepatic blood flow, the metabolism will get affected. Thank you.